Hi, I'm Danica Koopmans.
And I'm Sharon Hughes-Geekie. We're your hosts of Docs of Vernon. This is an interview and podcast series designed to help you navigate the healthcare system and get to know the physicians that provide your care.
Topics include what the heck is a hospitalist, treating addictions, and alternatives to going to the ER, plus so many more.
This is your link to healthcare in your community.
Today, I have the privilege of interviewing Dr. Lisa Heidt. She is a CCFP-EM trained physician who has a fellowship in addictions medicine, ISAM. She also has done medical volunteering abroad. One of the places has been Nepal. She also has worked in Vernon doing quality improvement on an opioid use disorder project that I'll ask you more questions about. And she's still going to be doing quality improvement projects provincially as one of the leads for Vernon Jubilee Hospital. This is a project called Loud, and I'm also going to ask her more questions about that. She's also a family woman. She's a mom of two. She loves running long distances and traveling with her family. So thank you so much for being here.
Thanks for inviting me, Danica.
I think we're all very excited to hear from you, so thank you. One of my first questions for you is, did you think you would get into addictions medicine?
That is a hard no. This is a very unexpected career path for me. I spent most of my career in the emergency department, so I was actually working around the province, but mostly in Vernon as a full-time emergency doctor until about 2 years ago. And then, I made an abrupt career change, ended up going back to school, to UBC, training on Vancouver Island, learning lots of new skills, and then coming back to Vernon where there was quite a clear need for this type of, expertise, collaboration, and was able to start an addiction medicine service, which there are a few across the province, but certainly not in every hospital, and has never been here in Vernon until that time. So we're about 2 years into that. It's now a full-time service. I've had another physician, Dr. Wiseman, join me, so we're kind of up and running full-time now, which is great.
Wow, that's really pioneering a role, because I think we at the hospital knew you were coming and anticipating this, and we were really excited, and then to see it already be growing in 2 years and just to see the results, it's incredible.
Yeah, it's been a really exciting time, lots of changes.
Yeah, and to pave the way for something like that too, right?
I definitely had mentors. It was a model that's been adopted in other hospitals, and so I was able to contact people who'd done the same, either in Kelowna or other hospitals. So that was really helpful.
Yeah,
I wasn't starting from scratch.
Yeah, absolutely. So what would a day in the life look like?
So I have, a kind of combination practice. So I work both in acute care in the hospital as well as I have a clinic in the community.
Okay.
So my time is split between both. So generally I spend most of my days here. I usually start at 4. I kind of work all day here. And generally I do consults, and those are requested from other physicians, from nurse practitioners, sometimes from my substance use connections workers. So they've identified someone who has a substance use disorder and felt that they would benefit from talking to an addiction medicine doctor. And that could be anywhere from someone with opioid use disorder, alcohol use disorder, some others, but those might be the two main ones that I would be consulted for. And I might see consults either in an emergency department, women's and children's, the intensive care unit, psychiatry unit, as well as any of the medical floors. So it's just I think a testament to how many people are struggling with substance use disorders, the prevalence of that in acute care, and just an opportunity, I think, to improve outcomes by collaborating with the other, physicians, nurses, nurse practitioners in the hospital.
Yeah, it definitely would take a whole team approach in order to manage something like this, because you're seeing it in hospital, but then you're seeing it in the community, And do you ever get patients who are like, I have a substance use disorder, like where they're surprised, or are most people pretty aware?
I would say it's definitely a mixed bag. Sometimes
Yeah.
we're kind of exploring new diagnoses, and sometimes we're seeing people with well-established decades of that diagnosis, and it's certainly a continuum in terms of readiness for change. And I think I can adopt my treatment plan to, wherever that might be. There's opportunities to improve health outcomes.
Yeah. So when somebody is consulted, or you are consulted and you go see them, do they refuse sometimes to have a conversation with you, or are they usually open to receiving care?
I would say the vast majority of time people are open to having a conversation with me. And I think like a measure of success is not whether someone's gonna quit after I've seen them. That would be not realistic. And I mean, often it can be anything. I think in acute care, often the end goal is keeping someone in hospital so that they can complete their medical treatment, whether that's IV antibiotics for their cellulitis or pneumonia, or mental health crisis. So I think a lot of the in-hospital treatment is really so crucial, because without it, if you force someone to go through withdrawal or get medical treatment, they will often, there's such a risk of leaving and then being at such high risk for adverse outcomes. And certainly with the toxic drug crisis, that includes overdose and death.
Yeah. Wow. That's such a good point. Like, often in acute care, what you're saying is we're actually wanting people to be well supported in their substance use, because if they leave hospital, then they're really at risk of worse outcomes than us giving them medication for substance use.
And there's lots of research done about the importance of well-managed withdrawal in hospital, and how it definitely leads to improved health outcomes. And that's what we're all about, because we're healthcare professionals.
Yeah. This way in which, sometimes we're trying to like physicalize, or it's not really a word, but trying to make something that's more of a mental, emotional, spiritual battle into a physical situation, even though yes, they're hand in hand and it's all holistic. But how do we change traumas and things that have already happened, and these are the results of that? So I think you just humanized it, and you said, like, we're not trying to fix and change people, we want to just meet them where they're at.
Yeah, it's a mantra I repeat to myself often. There's no other way, I think, to be effective in this line of work. Often what we're dealing with is a sequelae of adverse childhood events, whether that is physical, emotional, sexual trauma, and these have been people's coping mechanisms, in order to survive. And I think we have to deal with the physical withdrawal symptoms, which can be dangerous and life-threatening, first, but we cannot forget about the drivers of this illness. And I think that was like really my main learning point in learning about substance use disorders is those root drivers. And I don't know that that's maybe understood by, I certainly wasn't by myself beforehand. It may have been looked at as like poor choices, moral failures, just say no.
Dare.
I think we just have a much broader perspective of the like biopsychosocial model of it. And it is needing such a team approach. And I'll give a shout out to my social work team as well, who are instrumental in providing those psychosocial supports and treatment. And I think without it, the medication's effective, no doubt about it, and is standalone and important and can help prevent overdose deaths, but certainly I very much prefer to not utilize it in isolation.
Yeah, absolutely. Yeah. So one of my questions along that lines is around what are some of the misconceptions you hear from family, friends, even colleagues and people that you're working with constantly?
Well, I think it is really that. There is so much stigma about mental health, about substance use. And I think if people realize the life stories that most of my patients have, I think it's very easy to have empathy for the situation they find themselves in.
Yes.
I think it's pretty hard to be a caring human being without, and listening to some of these stories, and you can understand why they have ended up where they have.
Yeah, absolutely. Absolutely. So one of the things, that I think comes up a lot is, as we're doing this interview series, what is something that you really want the public to know about just the population group that you work with? Number one, who are they? Where do they come from? Are they all around Vernon? What age? What's some of the things that maybe would surprise the public to know?
Yeah, I think just the pervasiveness of this medical condition may surprise some people. So, like, my patients can range in age from mid to even early teens up to 7th decade of life.
7th decade, I love that.
And all socioeconomic levels are represented. So it's a human condition.
Yeah. It's a human condition. And one of the things we said at the beginning of the interview is really we all have addictions to something, It's just that it gets labeled differently, I think, when it looks ugly.
I think it's part of being human to want to change consciousness. And substances have been used in every culture going back to the beginning of time. But it becomes problematic when it turns into a substance use disorder,
where you no longer can function.
Where you can no longer control your use, and it starts to have consequences.
Yeah. Wow. Okay, so last question about that topic, and then I want to dive into a little bit more fun. Is there anything that really makes your job difficult?
Many things. Of course it's challenging. I think, like all of medicine, there's a lack of human resources, there's a lack of physical resources. So it can feel very hard to get my patients the help that I know that they need, and that's very heartbreaking. So I think that's my biggest challenge, is helping people navigate the system. There's often so many unmet social needs, whether that's a livable income, affordable housing, access to things like chronic pain management, physiotherapy, dental care, all these things that aren't necessarily easily accessible to some people.
Yeah. And I actually was going to ask you to talk a little bit about the project you're working on called LOUD that's going to be starting as an initiative at a provincial level. Because I think it's good for people to also hear at the end of the interview just where they can get access if they need support with addictions, or or substance use, or they know somebody, or how does the process work. And then just it's been interesting, you shared a little bit about the project, so if you could share that with
It's brand new, this iteration of it, so I actually don't know a lot about it yet. It's starting next week. It's our first meeting, but the first iteration happened about 4 years ago, and was actually kind of my introduction to this branch of medicine. I was an emergency physician at the time, and it was just an opportunity to like learn a little bit about how we could do things differently in Emerge. And I found it such powerful learning, and I found it could be so effective at the right time, because this emergency is where people go when they don't have other options. And that might be at 3 a.m, and there might not be a lot of other resources to call on. So by having some of the beginnings of knowledge myself, I found it was very rewarding, and it just made me want to learn more. So it was the initial start of my interest in this area of medicine.
Wow. Because because this project was specifically for people who came in and it was about identifying substance use early on. So maybe somebody came in and they had, let's say they had a pneumonia, and then you would assess them for the pneumonia, treat the pneumonia, but before all of that you would do sort of like a basic surveillance of like possible substance use and rule it in, rule it out, and then manage that as well. Was that what it was focused on?
So there's a few different quality improvement projects. So that one that you're speaking to was one we did last year, just with as a very small project, just a local project looking at universal screening for substance use disorders in really at the time of first nurse assessment.
Okay.
So that even if someone didn't present with substance use disorders or presenting complaint, that we would still have the opportunity to identify it early on in the visit and intervene by both like effective medications and psychosocial support, and enable patients to have a more successful stay, get all their investigations completed, be admitted and stay and complete their hospitalization if indicated. And we were able to increase screening rates from essentially 0 to 50%, which was amazing.
Wow, that's almost
so for a few months we had screening rates really get to a pretty good rate, and we were able to show a lot of positive outcomes, engagement in opioid agonist treatment, which again we know decreases overdose deaths, and also show the decrease in some adverse events. So we call them PSLS events. We were able to measure those, show a dramatic decrease, and that might be things like substance use exposure within the ED, verbal aggression, physical aggression, and leaving kind of prior to ED visit being completed.
Wow.
So it had a lot of positive outcomes just by asking a question, recognizing we can't diagnose these conditions by looking at someone, and just making it a universal, non-judgmental, open-ended, with the availability to then link to effective treatment.
Yeah, that's actually incredible. Do you know, are they doing that in most emergency rooms, and Vernon has just kind of caught up to that, or is that something more new that we're doing in Vernon?
I think, well, in part, I think it's recognized that it's important and effective. So as part of the sequelae of this study, we're now measuring screening rates across IHA. So it is being standardized now, and there is another kind of quality improvement initiative going on within the health authority to measure that and outcomes associated with it.
Yeah, wow. That's great.
Yeah,
thank you.
Exciting.
Another thing you're spearheading.
Well, I'm not spearheading that. I'm kind of just a cog in the wheel of that one. Definitely not spearheading it. But I'm involved, and I'll be rolling out the Vernon site, which will be one of the first interior health sites. So that's coming at the end of March.
Wow.
Yeah, so there's lots of research, there's lots of quality improvement, there's like it's kind of like a clinically exciting field right now. So I'm really happy to be part of that part of it. That it's not, I also love the one-on-one patient interactions, those really powerful stories. But I love more of a systems approach as well.
Yeah, you want to see the data match what the, anecdotals and the stories you hear.
Yeah, it's nice to take it from that kind of close level all the way to like the broader overview.
Yeah. Oh, that's amazing. So outside of medicine, I know you love running and you love to travel with your family. What does that look like just with work-life balance, and then maybe touch on kind of your favorite thing that you're really doing with your family right now?
Yeah. So work-life balance is a struggle for all of us, but I do try to be really mindful. My kids are teenagers. I don't have that much longer with them, so it's quite precious these days. So the last few summers we've tried to take some extended chunks of time as a family off the grid. So we do try to take some extended chunks of time. The four of us, and our favorite thing to do is like hut-to-hut treks.
Cool.
So we did a fantastic one. It was called the Oak Route, and another one through the Dolomites. So that's just been a really, really special time with our family.
Yeah, absolutely. And what's the next one you're planning?
That is a good question.
So
We talked about like the Zote Aurora route in New Zealand. I'm probably pronouncing it wrong, but like North Island to South Island, that's like hardcore, like I think multi-month, but that might be in the coming years.
That's
I would love to do
amazing.
something like that.
Yeah, absolutely. And what about in Nepal, having done some volunteer work there? Like, is that?
I've been there a couple of times, once as a traveler and once as a medical student, and both times got to do some amazing trekking in the Himalayas, and then spent some time doing a research project about childhood disability. That was in rural Nepal, kind of in conjunction with, I think they might have only had one medical school in Kathmandu, but we were kind of paired with the medical students there.
Wow.
Which is really cool.
That's very cool. So before we end our interview, is there anything else that you want to share that would be of value to the public?
I think like maybe to the medical learners especially, just I think seeing value in working collaboratively, with addiction medicine and other branches of medicine, just knowing what an opportunity acute care is to improve outcomes. And you might not know it, but I've got so many powerful stories of the difference because of a hospitalization. And I've now been able to follow those patients for 2 years.
Wow.
And just seen such beautiful things happen. And I can't think of very many areas of medicine where that is possible. So it's really my privilege to get to walk alongside people as they kind of come out of severe substance use disorders and are able to transition back, connect with their family, with their children, with their jobs. And that's like my favorite part of doing this work for sure, is seeing those really incredible good news stories. So I think like also the public might not be aware of those, but this is really effective. It's not perfect, it's far from perfect, but it's pretty amazing.
Yeah.
Yeah.
And those stories keep you going.
Yeah, 100%.
So thank you so much for sharing and your wealth of knowledge and for being here. If anybody would like to connect with Dr. Heidt or would like to, continue following in the interview series, all of the links are down below. If you want to become an addictions medicine doctor or join our team or locum, you are an addictions med doctor, please stay tuned and follow the links below. Thanks so much. Bye for now.
Bye.